We will start with a case. We will start with the faculty presentation. Today we have Dr. Vidya joining in to take a session for us. We will have a presentation by her for the first 40 to 45 minutes, followed by its discussion. And around 3:30 we can start with our case presentation taken by Dr. Malavi. So welcome all to the third session. Over to Sridevi, Doctor.
I think Raju, you already invited her. So, and again, I'm so happy to invite Vidya again and again to the session. She's a very good friend of Pallium India, and sessions are all very good. She is an assistant professor in Homi Baba Cancer Hospital in Vizag. So today we'll hear from her and interact more after the session. Should we start, Vidya?
Thank you very much. Good afternoon, sir. It's so nice to see you, and presenting in front of you does make me nervous, but then I always have the confidence that you're there with us, so that if there are any questions, then they can be addressed to you too. And Sridevi, always a pleasure and very nice to meet you all. And I'm speaking from Visakhapatnam, where the temperature is nothing like what it will be in Dehradun. And I hope that you can ask us questions, because it's a little hard when you speak on a virtual platform. I don't get to see many of you, and so the reactions and other things would be difficult. But if you have a problem at any time, you can always stop and ask, or we could do it at the end of the session. And today I've been told to talk on opioids, focusing mainly on the step 2 and step 3, the opioids in cancer pain. And as I deal with cancer pain most of my examples will probably be in relation to cancer pain. So before we step into opioids, there are a few things that I think is very important, that by now, before we have started deciding what medication we are going to give the patient and that we are going to give him or her opioids, that we have assessed the pain. I think that is very crucial. We have assessed the pain. We are sure that opioids are going to work for this patient. We know where the pain is. We know the severity of the pain. We know the type of pain. We know the background medications the patient is on. We know what are the other medications the patient is already taking to what he or she has responded. And second, it always helps to know if this pain is opioid responsive. And because there are a few pains which are not opioid responsive and for whom it's pointless to even try. Like if you have had these classes in the past, it would be when you have pain because of raised intracranial tension, or you have had spasms, or you are having muscular pain or headaches. For this, opioid is not the first choice. And the role of adjuvants. We should always remember that we are starting the patients on opioids, but putting them with adjuvants along with opioids go a long way in making the patient most comfortable. And one should never but one should always have the role of disease-modifying therapies in the background, because like how usually when I counsel, I tell patients, because they come to us rather early. They come to us when they, even sometimes before diagnosis or even at the start of chemotherapy. So usually the way I explain to them is that the oncology medicine is going to take care of your disease, trying to control that. Whereas the medicine that we are going to give you is going to make your brain not feel the pain. Because many times, once pain comes down, patients feel that all is good. So it's very important when we address chronic pain to get this message across to the patients that what we are trying to do is not make you feel the pain. So the role of disease-modifying therapies along with pain medication is what helps the most. And more than anything else is, of course, the concept of total pain. In palliative care, which should be done everywhere, total pain should never be ignored. And working at the Cancer Research Institute where you all are, I think each one of you is strongly aware of how important the concept of total pain is. How important it is to know the background of that person, not just the pain. So right now, our focus is going to be on the medication, but this is something which is mandatory. So the fact that psychologically what the patient is going through, what is the extent of physical pain, what is the kind of background that he or she is coming from, what is the kind of support that they have, is very, very crucial for our opioids to work. Can I have the next slide, Rajeshri? Thank you. So as we know, most of you must have been introduced to the step ladder, which is step 1, step 2, and step 3. So in step 2, we have opioids for moderate pain, but along the step ladder, there is something that we shouldn't forget, and that is, even when we go to step 2 and step 3, we will not be forgetting our step 1. We always add an NSAID, we always add paracetamol, and they work very well together. And the adjuvant, suppose there is an element of neuropathic pain, you add that adjuvant. If you want to give a steroid, you add that. So we never forget our step 1. So it's not like I've given morphine and my chapter closes with morphine. No, it is along with morphine, you give this so that you get the best optimization of pain. Next slide, please. So now we have assessed this pain, and this is a person who has come to you with this expression, with this very severe pain. So how are we going to, and we have found out his pain, and we are going to try, we have decided that we have to try opioids for this patient. Next slide, please. So this is a 56-year-old. He has carcinoma of the larynx. Severity-wise, his pain is 10 on 10. He says it's sharp. He says it's just there. I'm not able to sleep, which is one sign of very severe pain. Last 2 weeks, how will you manage? Even before I get a better history from this patient, I need to bring down his pain. So how did I do this? Next slide, please. So that is something that we do for us to know how this is going to work, and for pain to be brought down as quickly as we can. We have what we call as an intravenous morphine trial. So we can give it intravenous. If we want to do the intravenous morphine trial, never forget metoclopramide, because that's very important, as this patient will just start vomiting and then he will refuse the pain medicine, which is going to help him the most. So we start with injection metoclopramide, give him the injection, and then we give him injection morphine, 1.5 milligram at every 10-minute interval. Next slide, please. And the end point would be when he gets pain relief or when he feels sleepy. So we give him, we usually dilute it in the syringe, 1 ml and 10 ml, and 1 ml contains 15 milligram of morphine. So it becomes 1.5 milligram with every 1 ml. So we inject 1 ml of morphine, we wait for 10 minutes, and then go to the next ml. So the end point would be, suppose he says, yes, I'm getting pain relief. How do we grade this? Can I have the next slide, please? So this is how we'll grade it. That at 10 o'clock we started, his pain score was 10, but he was not drowsy. We gave him 1.5 milligram. His pain score came down to 7. We give him another 1.5 milligram. At the same time, we are monitoring his pulse rate, his respiratory rate, and his blood pressure. And then we come down, and the minute at 10:30, we see that his pain scale has come to 1, and he's not drowsy, we stop. So now, next slide, please. We have given him 4.5 milligram of IV morphine, which has given him good pain relief. So the dose that we will start with would be 5 milligram every 4 hours. Now, in an OPD, usually that's what I do. It's very hard for us to give IV morphine trial to every patient who comes to us with severe pain, because it's a busy OPD like what we see in most of our places of work. So can we give an oral morphine trial, which is what we do most commonly? Next slide, please. So here, when we give an oral morphine trial, what I usually do is, if a patient is opioid naive, he's not taken opioids, I give him a Perinom tablet. After that, I tell him to take his 5 milligram of morphine. We tell him to wait out in the OPD for about half an hour. And we have graded his pain. We have found it severe. It's 10 on 10. After half an hour, he comes back to us and tells us how much pain relief he has got with that 5 milligram. And if you feel that the pain relief is adequate, then we start him on this dose, which is 6 a.m., which is 5 milligram, 10 a.m., 2 p.m., 6 p.m. Bedtime dose is always double, because Between 10 in the night and 6 in the morning, we have 8 hours. So we clearly tell the patient, please don't get up in the night at 2 a.m. and take your medication. Double the dose at bedtime. And the last column is most important, because as we go over the series in the next few minutes, you will understand why that SOS medication is so important. Because this is something where the dose is adjusted based on the response to pain. So that is why the SOS, or the breakthrough medication dose, or the rescue dose as we call it, is always the 4th hourly dosing. So when we give our instructions, please don't forget to mention that SOS take the same amount of medication. So this is how we give oral morphine by the clock and by the mouth. Next slide, please. So we start with 5 milligram in opioid naive, and suppose a patient has come to you and said, I'm already taking morphine. Most probably somebody else has given it to him and they have not taken the dosing right. He has started the medication, but his dose is not getting adjusted. Or somebody who's already on 3 or 4 tramadols in a day. So he's already taken tramadol. In those patients, you may start with 10 milligram. But like what we follow in palliative care most of the time, start low and go slow. So it really works well that way. Next slide, please. Can you answer this? So now we had this patient, Mr. X, who was started on 5 milligram of morphine every 4 hours and SOS. He was relatively pain-free for 2 weeks. Okay, he was relatively pain-free for 2 weeks. But then he needed 4 SOS doses of morphine per day for the last 4 days. So what do? So 4 doses means he's taking 20 milligram in excess. Next slide, please. So when 2 or more than 2 PRN doses are taken, we have to start increasing the dose by 30 to 50% every 2 to 3 days. So this is the reason why morphine is not a drug that you can just prescribe and tell the patient to go. There is something called review that needs to be done in every patient whom you have started on oral morphine. We usually tell the patient, because it's hard to tell all patients to come back based on the distances where they stay, that if a relative can give us a feedback, if they live in the vicinity, we tell the relative to come back and give us a feedback. We tell them to draw a little chart, write the timing, write down how many extra doses they have taken. We do the calculation and then we can tell the relative. But many a times we still have to do this over the phone because of the distances the patients live in. Next slide, please. So how frequently would you give SOS doses of morphine orally, and why would you do that? Next slide, please. So the next slide. Yeah. So this brings us to the pharmacokinetics of morphine. So the SOS doses, when we tell them, because the kind of morphine that we start with is always the short-acting morphine. So when we start with the short-acting morphine, it works for 4 hours. So when we give SOS doses, we count and we increase the doses. Now, we also have other preparations of morphine. So for us to understand why we should give these doses and how frequently we should give these doses, a little bit about the pharmacokinetics of morphine. So this is the absorption, the distribution, the metabolism, and the excretion. Next slide, please. So when we take that tablet of morphine, it goes into our gastrointestinal tract. It gets absorbed from the upper small bowel, and it goes from there into the blood vessels, into the portal vein liver, goes through the first pass hepatic metabolism, and then into the systemic circulation. So next slide, please. The metabolism is mainly in the liver. A minor part of it is in the GIT and the kidneys, and the metabolites of morphine are what we call as morphine 3-glucuronide and morphine 6-glucuronide. The component which gives pain relief is the morphine 6-glucuronide. So that is the active component which gives pain relief. Next slide, please. And it gets absorbed in the upper small bowel. So there's one thing that you should remember: whenever there is gastrointestinal hurry, your absorption is going to suffer. So these are the things. That is why it's important to understand absorption, because suppose you have a patient in whom you have a pathology there, or in whom you have a feeding jejunostomy. So you might have to work around dosages for these patients. So you should understand that that is where most of the absorption takes place. It's a hydrophilic drug. So it's a slow onset of action. It takes a longer duration of time. And the way the drug gets very well absorbed is the subcutaneous and the intravenous route. Next slide, please. When we give it sublingually, the absorption is low and it has a bitter taste, though many a times we still have to crush the tablet and give it through the buccal mucosa, though there is a lot of variance in the way it gets absorbed. Next slide, please. And intravenous is the most effective route because the bioavailability is 100%. Orally, if the bioavailability is only about 30 to 40% or 20 to 30%, whereas intravenously it's 100% bioavailability. And by giving it intravenously, we are eliminating the first pass hepatic metabolism. Next slide, please. So when we talk of bioavailability, it means this is the percentage of administered drug with access unchanged into the systemic circulation after we give the medicine orally. Next slide, please. So what gets absorbed and what is bioavailable is not the same. Like I said, absorption of morphine can be 100%, but what is available, what is the bioavailability is only 20 to 40% when we give it orally. Next slide, please. And we also have controlled release preparations in morphine. So to achieve the expected absorptive profile, you need to maintain that length of time. So we give it as 2 medications. But there are a few things that we need to remember before we prescribe a controlled release preparation. Now, this is something I see very frequently. So many a times, especially when morphine is prescribed by probably the non-palliative care or when it comes from oncology or other sides, they just write down 10 milligram sustained release preparation BD or 30 milligram BD and send the patient. Now, first thing is the dose has not been titrated. So no one knows what is the dose that is actually working for that patient. So this is a random 10 milligram BD or random 30 milligram BD, which is really unsafe to start with. Secondly, it doesn't help the person because he's given the drug. We don't even know if that is the quantity he requires per day. And the saddest part of it is this is given in patients who are taking feeds through a Ryle's tube. So they are going to crush the preparation and they're going to push it through the tube. The minute you do that, a sustained release preparation now becomes like an immediate release preparation. So you have a patient who is intensely drowsy when he takes the medication and who suffers in pain for the rest of the day. So that is why it's important to understand that when we are titrating the dosage for pain, when we are titrating the medications and deciding what amount of drug the patient requires, we never use controlled release preparations. That is when we need to use the immediate release tablets. We need to invest time in every patient. There is no escape from that. We have to make them understand that every 4 hours you have to take the medication. And why every 4 hours? Because the medicine works for 4 hours. Invariably, the patient looks around and tells you that if my pain goes away, so I stop taking it. So one more warning. If the pain is not there, please continue at these times because otherwise the pain will come back. So we need a way to communicate with the patients and to the relatives because it's very easy for us to write down 610 to 610, but there may be no one working in that house. There may be people who cannot read the time. So it's the problem start from there, but we have no escape. We need to find a way around this. And so that is where it helps. The conversation before writing a prescription of morphine is so very important because it's very easy to say patient is non-compliant. But the patient is non-compliant because you have never invested that time and sat and told him or her how important it is to maintain these timings. So it's not just about writing the timing and giving them a perfect prescription. It's also trying to find out what are the problems in that family which can prevent that patient from taking the medication on time. And be very careful when we give a controlled release or an SR preparation. When pain is well controlled, nicely titrated, the patient can take orally, there is no disturbance anywhere there. comfortably give a sustained release preparation. But never start the process with a sustained release, and always be cautious that when a patient is on a rise tube and is crushing the medications, please don't give them a controlled release preparation. Next slide, please. So the various preparations that we have as aqueous solutions, we do not have it at our center. As far as I know, I don't know about Kerala, but I think they have it in Kidwai and other places, but we do not have it here. There are tablets, like I told you, immediate and controlled release, and the injection, which is 15 milligram per ml, which we use in the subcutaneous as well as the intravenous route. Next slide, please. Now, this is a patient, Mr. X. He was on 10 milligram of morphine, comfortably settled for 4 hours, every 4th hourly for the last 6 months. Today, he's come to you with drowsiness. And when you examined him, you found that he had a serum creatinine of 5 milligram per dl. Next slide, please. So what will you do with the morphine dosage? For this, we need to understand the excretion of morphine. The minute you see this level and the minute you see this drowsiness, don't panic and say, I'm not going to give this patient morphine even for pain. Because for that, if we understand how this drug is excreted, it's by glomerular filtration, and M6G is the one that accumulates in renal failure. So what happens is your creatinine clearance decreases, the half-life of the drug is prolonged, so the toxicity increases. Now, it's in the Western world or whatever literature we read, the first thing that we are taught is switch the opioid. We have to probably give him, add the adjuvants and switch the opioid to fentanyl, which is probably a better opioid among those that are available for us today. But like we know, most of our patients come from the really lower socioeconomic group. And if we tell them fentanyl, they'll probably afford one patch, and after that, they'll just disappear and they will suffer with pain. So what we usually do is, in these patients, instead of a 4th hourly dosing, we increase the spacing. So we make it an 8th hourly dosing. So we make it a TID dosing. We reduce the dose, we add adjuvants, or we switch the opioid for a short period of time, try to get everything in place, and then after that, continue with the TID dosing. Next slide, please. So now we have Mr. X, who was sent home on tablet morphine, and after 2 months he comes back to you and they say we cannot give him morphine because he's unable to swallow anything and he's in severe pain. So now what will you do? So which brings us to the other routes of administering morphine. So we can give an intravenous or a subcutaneous route. The oral route, the intravenous route or subcutaneous, the first two are the ones that we usually use. So when patients are this bad, then at that time we do not have much of a choice, but we have to put them on a subcutaneous morphine infusion or an intravenous infusion. And but the limiting factor with that is that this patient will now need admission. So you need to have a backup plan. You can't just say that I'm going to start the IV and subcutaneous route and after that turn around and say now what. So we need to have a backup plan. If there is something that has caused that difficulty in swallowing, if it's a fungal infection, if it is anything like that, then we address that. And then after that, try and go back to what the patient was taking. So these are the various routes. The two most commonly used routes in our setup are the intravenous and the oral route. I can see a lot of surgeons over there. What's suddenly happening? Okay, I don't know. All right, next slide, please. So which brings us to the fact that how do we choose opioids? Like we understand that it's based on severity, and like it has been taught to you and told to you that it is not that you have to go step 1, step 2 and step 3. If the pain is severe, if the pain merits the opioid, we go directly to step 3 and we add medications from step 1. So even choosing the opioid, yes, it's based on severity. And what are the other, few things that also which we need to know? So suppose we have Mrs. X, who's on 50 milligram Q4 hourly morphine. One day she's just come to your clinic and she has severe pain. Your immediate temptation is, can I just give her an injection pentosukin? Instead of telling her to wait and take her oral morphine. So is that right? What are you doing? Your thought, is it right? Or is there something better that you can do? Then you have Mrs. N. She's somebody with breast cancer. She's got brain metastasis. She's received radiation to the brain. She has moderate pain on her breast. So moderate pain merits a step 2 opioid. But go back to her history. Is there something more you need to know, and how will you manage? Next slide, please. So when we talk of opioids, it's a general term. So these are naturally occurring semi-synthetic, synthetic like methadone, which produce their effects by combining with the opioid receptors. Next slide, please. So the receptors that we have are the mu, kappa, and the delta receptors. Next slide. This is like what it's found in several areas of the brain, and the spinal cord, and the peripheral nervous system. Next slide. And when we go to each of the opioids, codeine is a step 2 opioid. So there are a few things that we need to take into consideration before we give Mrs. X that injection, or before we give Mrs. N the step 2 opioid. So once we know this, then we will be able to choose the opioid better. Codeine is 1/10 as potent as morphine, but it's a prodrug of morphine. So after you give it, it becomes morphine in the body. The bioavailability is 40 minutes. The onset of action, it takes about 30 to 60 minutes, and it works for 4 to 6 hours. Where do we prefer codeine? Next slide, please. We use it for pain relief, yes, cough suppressant, and an antidiarrheal. We do not get codeine in our parts at all. So initially we used to use it as a cough suppressant, but now I don't really get the medication here. So we use very less of codeine. Next slide, please. Dextropropoxyphene has a 1/12 potency of morphine, and duration of action, again, 6 to 8 hours. Next slide. Now, tramadol. This is the most common opioid in the step 2 that we use. The advantage with tramadol is it acts on the opioid receptors, and at the same time, it has a TCL, tricyclic action. So it inhibits the reuptake of serotonin and noradrenaline. Next slide, please. The potency is 1/10 of morphine when you give it in the parenteral route, but if you give it orally, it's 1/5 of morphine. It has a very high bioavailability orally, but the one side effect of tramadol is the intense nausea that it can cause. So you can put the patient away from pain medication just by not addressing this. So whenever tramadol is prescribed, especially for the first time, make sure that you have your antiemetic in place and your Paranorm or a metoclopramide in place, because otherwise it can be a very, very bad side effect. Another thing with tramadol is that it lowers the seizure threshold. So any patient with brain mets, any patient who's on medication for seizure, any patient with disease in the brain, we usually avoid giving tramadol, and we go straight to step 3. We don't give them tramadol. Next slide, please. Fentanyl is another preparation that we see and which we use. We have the intravenous route, but what I'm sure most of you must have seen and most commonly used is the transdermal fentanyl. We do not get the oral transmucosal, the fentanyl lollipop, which could be very useful for breakthrough pain, but we don't get it. It's a lipophilic drug. So how it acts is we use the fentanyl transdermal patch. We stick it on a place where it's visible, and it forms, next slide, please. It forms a nice depot. So after it forms the depot, then the analgesia effect begins. So something we need to know, because I keep hearing this again from our colleagues, that, oh, morphine is not working, switch to fentanyl. It's not so simple, because if morphine is not working, let's first find out why the morphine is not working. Is your dose right? Are you giving it on time? Is it adequate? Those are the factors that we need to see, because it's sad, but if morphine doesn't work, fentanyl just may not work. So it is not a drug that you give because morphine doesn't work. It is a drug that we choose to give in certain specific conditions. Like suppose a patient has an intestinal obstruction on opioids. That's a time when we can switch to fentanyl for some amount of time. Or suppose we have a patient who has severe side effects, who has myoclonus, or who has such severe constipation that you just cannot get over that, or intense itching, or a patient who is in hepatic coma, who was on opioids, then could we give them fentanyl because the patient is unable to swallow. So there are specific indications that we need to use fentanyl for. And another very important point with the transdermal fentanyl patches, if a person is opioid naive, it's very risky to stick the patch because you do not know how this patient has ever responded to opioids. Because we usually use the patch after calculating the morphine dose. So we calculate the morphine dose and then we come to a figure which says that so much fentanyl will help this patient, and that is when we use the fentanyl. And the minute we use fentanyl, we can't tell the patient you're going to get immediate pain control, especially to a patient who has used morphine and achieved it, because it takes 12 hours for fentanyl to start working. Only after that underlying subcutaneous depot is formed, it will start working. So for the first 12 hours, after the patch is stuck, we have to instruct the patient that they have to take their regular dose of opioids. So one that cannot be stopped. And even after that, we tell them to take SOS and then come back to us in 2 days, and we may have to even readjust the patch strength because again we start low. So sticking a transdermal fentanyl patch, one should think about these things and then do it. In patients who are very febrile, again the patch may not work. The skin condition, patients who have severe cachexia, that there is just no fat underlying, your choice of fentanyl may not be great for them. So, and for unstable pain, please do not use fentanyl, because when you have unstable pain, the first duty is to bring that pain under control. Only then you can decide what are the medications to use. Next slide, please. This is another patch which many of our patients who come from the periphery, somebody just sticks it onto them, and literally in the OPD, almost every day I am searching for patches on patients because some of them have even forgotten that it has been stuck, and they just come, and then the minute you ask, they say, oh yes. Or if they have a huge bill and they say we paid 2,000 rupees, I'm sure there's a buprenorphine patch stuck somewhere on that person. So these are not healthy practices, because buprenorphine could be very good post-surgical pain, but for our kind of pain, somehow we find morphine and fentanyl working way better. This has a ceiling dose, and we do not usually, the tablets are usually not used for pain control. They're used in injectable and transdermal preparations are available. It's a transdermal patch that we do see patients coming in. Now, why do I say these things about buprenorphine? Next slide, please. So there's something called before I come to that, there's something called an equipotent dose. So like we discussed, 1/10 of codeine and tramadol 1/5 orally and 1/10 parenteral. And if you want to switch from oral morphine to a subcutaneous route, halve the dose, make it half. If you want to go from oral to IV, make it 1/3. So suppose 90 milligram is your dose of oral morphine in 24 hours. Through the subcutaneous route, it becomes 45 milligram. And through the intravenous route, it becomes 30 milligram. Next slide, please. So what we mean by potency and what do we mean by efficacy? Efficacy is the maximum response that is induced by the administrations of the active agents. So after you're increasing the dose, after you're giving the pain medications, and you are looking at the side effects, what is the degree of analgesia that you have achieved? That is what efficacy means. When we talk of potency, potency is pharmacokinetics. It means so much of the drug is entering the circulation, so much of the drug is reaching the receptors, and so much has an affinity to the receptors. Next slide, please. So that is why we classify opioids as agonists, antagonists, and agonist-antagonist. And in the agonist-antagonist, we have what we call as a partial agonist, which is what buprenorphine is, and mixed agonist-antagonist. Next slide, please. So agonist means it's like morphine. It's a drug which has an affinity to the receptor. It induces the changes in the cells, and they have no clinically relevant ceiling effect to analgesia, which means you increase the dose, the patient either gets pain relief or he gets a side effect. Next slide, please. So this is how the graph will look. You keep increasing the dose, the analgesic effects increase in a log linear fashion. And this, so you either get good analgesia or you get a dose limiting side effect. Next slide, please. So the agonists that we have are morphine, the codeine, tramadol, fentanyl. All of these, we can say tramadol, of course, beyond 200, we do not go. Then we switch to morphine per day. And so these are drugs which have an agonist action. Next slide, please. When we say antagonist, it says it is something that is going to interfere with your agonist. So it's a competition. The antagonist binds to that receptor. It competes for those receptor sites. Next slide. So you have naloxone, which we use when we have toxicity with morphine, or naltrexone, which is used for, if suppose the side-limiting constipation is too much, there are medications that are used. Next slide, please. And when we talk of agonist and antagonist, these drugs have a ceiling effect for analgesia. So even though they may produce analgesia when the patient is opioid naive, they can precipitate withdrawal when patients are already physically dependent on morphine-like drugs. So they are agonists at one receptor and antagonists at another. So suppose somebody is already on morphine, these medications will not work as well because they can precipitate withdrawal in these patients. Next slide, please. How do they do this? So that is where we have pentozokin and buprenorphine. Buprenorphine is a partial agonist, and it has a low intrinsic activity in itself. It has a ceiling effect, and when you give it along with an agonist, it is going to reduce the pharmacological action. Next slide, please. So this is how an agonist-antagonist will behave. When agonist will give you a good pain relief with increasing dosage, and agonist-antagonist will actually start nullifying the good effect of your agonist. Next slide. So remember that case history when we said our Mrs. X was in severe pain and she was already on morphine and she's come to you with intense pain now. You had the choice between using pentozokin or you had the choice to give her morphine. What would you give? If you had given her pentozokin, what would have happened? Pentozokin has an agonist action at the kappa receptors, but it is weakly antagonistic at the mu receptor, whereas morphine is a mu agonist. So what will pentozokin do? It will go and replace the morphine from the mu receptors. Next slide, please. So that is why choosing the opioid is important. So your pentozokin may not have really helped this patient in the long run. So that is why we need to choose opioids carefully. And that's precisely why somehow in palliative care practice, unless the patient has already an established low dose of morphine and the patient has renal failure, which is when probably the buprenorphine patch would help. Most of the times, for us, morphine, fentanyl are the opioids of choice, and of course, tramadol. Now, in the other patient who had moderate pain, though her pain was moderate, she had breast cancer with brain metastasis after having received radiation to the brain. So in this patient, we will avoid tramadol, and we will probably just go up to step 3 if needed, or stick with step 1 and then add adjuvants. If that doesn't help, go directly to step 3. If there is nothing wrong in omitting step 2. Next slide, please. Now this brings us to one of the last sections about in the absolutely didactic conversation that we have been having, where I've just been only talking and just looking forward to listening to your inputs too. So in the side effects, so adverse effects with the therapeutic doses. Next slide, please. So like we have been taught, and we have been taught everywhere, wherever we've been trained, the hand that writes morphine has to write a laxative. There is no choice in that. The minute you prescribe morphine to your patient, or you prescribe an opioid to your patient, and you do not give a laxative to that patient is never going to be compliant to your pain medication, because you have made his or her life even more miserable than what it was. So constipation is one of the adverse effects of the drug which will never go away. So you have to give the patient a good laxative. And choosing the laxative again is paramount, because the easiest thing to write nowadays is loose, which is lactulose. Doesn't really help, most expensive. So what we need here is a stimulant laxative. It's a stool softener. So the laxative of choice would be bisacodyl. or it would be sodium picosulfate or senna, one of these laxatives. And in palliative care, we never prescribe bulk laxatives. We do not give those because the patient will not really have a good time taking those laxatives, and it really won't help. So the laxative of choice would be cremafen, which is a stool softener, cremafen P with sodium picosulfate, and bisacodyl. And bisacodyl is available in tablet form, and bisacodyl is available as suppositories. It always helps to counsel the patient and tell them, because the first response you will get is, the patient is not eating. What do you expect him to pass to us? The second response that you will get is, but I have never had a problem with motion. But you have to make them understand that your giving morphine has now caused this problem. And so they have to adjust the dose of the laxative and take it, because it's not like the same thing will work for everyone. Nausea, vomiting is another side effect, but usually we see that when the patient takes opioids for the first time, after a few days, this side effect wears away. And again, it's important to stress that our favorite drug here, if you ask even a pharmacist, is ondansetron. So by giving ondansetron is a very good drug, but where does it work? It works much better for chemotherapy-induced vomiting. But when we are talking of morphine-induced vomiting, we would benefit with metoclopramide. So we have to give them metoclopramide, tell them to take it twice in a day or thrice in a day for the first 2-3 days, and once the vomiting comes down, they can then taper off. And ondansetron also causes constipation. So again, we'll be doing a disservice to the patient if we do not choose the right medication for constipation, for nausea, for vomiting. Sleepiness and tiredness can be there, because another reason for this is the patient has borne pain for such a long time, and so that initially 1 or 2 days till there is dose adjustment, they could feel sleepy, they could feel tired. But once the patient settles down and takes the medications properly, you may not even be able to differentiate him or her from somebody who's not taking morphine. Itching is another side effect that we see. We do try to control itching and dry mouth. But if itching can get, in some patients we have seen, though we have given them all the medications for itching and they still do badly, then we may have to switch opioids. Dryness of the mouth is something we have to explain to them. So we tell them to take regular sips of water. Urinary hesitancy is another side effect, especially when you're going to start medication and this is an elderly man who already has a prostate issue or an elderly woman. You have to ask for the history. You have to ask them, how are you passing urine? If necessary, we may need to add a drug there. Next slide, please. So like I already discussed, a stimulant laxative works best. Next slide. Next slide, please. And vomiting is usually self-limiting. And again, like what I told you, these are the drugs, the stimulation of the CTZ, and so it occurs in 1/3 of the patients. It's self-limiting, but you need to give them a medication, otherwise they will vomit the morphine also, and so they don't get pain relief, they get vomiting instead. Next slide, please. Yeah. Next. So the drugs of choice are haloperidol, metoclopramide, and domperidone. Haloperidol is a little difficult to get in our area, so that's why for us metoclopramide becomes the first drug of choice. Next slide, please. Sleepiness and tiredness, again, it's a self-limiting adverse effect. Next slide. So when we say toxic effects, now what we saw were adverse effects, something that we can control and something that the patient need not stop the drug for. But if the patient goes into delirium, if the patient comes with myoclonus, the patient comes with intense drowsiness, we have to revisit. One, is this the right drug for this patient? Is the person responding well? Delirium, we need to rule out all the other causes of delirium, because delirium can have a wide spectrum of causes. It could be metabolic, it could be sepsis, it could be hepatic failure, it could be renal failure, it could be your morphine causing delirium, it could be terminal delirium. There are so many causes for delirium. So based on where the patient is in the disease trajectory, based on what medications he's already on, you have to assess the cause for his delirium and find out if your morphine has done this damage. Myoclonus. Again, myoclonus is because of the M3G component. So in the metabolites, the M6G is the one that is an analgesic. It's the M3G which can cause this intense myoclonus. Myoclonus is usually, patients will clearly come and tell you, like we've had patients, when you give them, they're okay with 5 milligram 4th hourly, they went up to 10 milligram, they went up to 15 milligram 4th hourly, they went up to 20 milligram 4th hourly, and then they touched 30 milligram 4th hourly, and then they came and told you, oh my God, you know what, this time I'm getting these jerks. So your ears should always be open for that. The minute they say jerks, then you have to ask them, because it's not like if the patient has done well with 5 milligram 4th hourly, he's going to do well forever, because myoclonus can come at a certain dose. So usually what we do in myoclonus, at that time the myoclonus is bad, we have to switch the opioid. Drowsiness, intense drowsiness, and that is precisely why when there is unstable pain and when the patient is having some disease modifying therapy, like suppose you're sending your patient for PAL-RT, you're sending your patient for palliative radiation, at that point, if you have a fentanyl patch, or if you have given the patient a controlled release or a sustained release morphine, it may actually be an adverse effect, because the patient could be drowsy, because his pain comes down because of the radiation, and now the dose that you have is higher than what you should be giving. So that is why it always helps. You should always keep in mind choosing the opioid, choosing the route, choosing whether it's short acting, long acting is all important. Next slide, please. Now, this is something we are asked all the time. Does it produce respiratory depression? The kind of medication that we give, which is oral, combined with gradually increasing the dose, ensures that respiratory depression is unusual. We almost never see it. Okay, because when we give tablets by the mouth, when we are slowly increasing the dose, when we are monitoring the patient understands the medication, it's very hard to see respiratory depression. Next slide, please. And so when you have respiratory depression, don't blame the morphine first. First, find out if the patient has pneumonia, has any other factor, or is the patient taking another sedating medication? Again, very common, because my cardiologist gave me this. My so-and-so physician gave me this. So our patients have so much of polypharmacy that we need to sit down and ask what medications that they are taking. Next slide, please. Opioids causing addiction. Again, this is something which is in our setup, we hardly ever see it. Substance abuse as a result of medical use is low. But for that, there is always a confusion whether the patient is physically dependent on the drug or psychological dependence. Most of our patients are physically dependent on the drug. But there is also something that when we have, like what they say, when you have the, it's always a responsibility. So suppose we are prescribing medications to patients whom we cannot see, which happens most of the time. They come only once in a month or once in 2 months. They live far away. The relative comes to meet us. It always helps to talk to the patient over the phone, to ask them how they're taking the medications, to bring back these slips that they're taking, and to keep a limit. Like every hospital can have their own limit, saying that I will give medications for, say, 1 month at a time. So, and there are also questionnaires actually before you start the patient on opioids to find out if they have, history of substance abuse, history of alcoholism, history of smoking and other things, just to know that what kind of a patient could probably get addicted. But in our finding, in our kind of setup, in a cancer institute, it's very hard to really find patients who have psychological dependence or addiction to opioids. Next slide, please. So we usually overestimate, from the risk of addiction. Next slide, please. Yeah. So when just defining addiction, it's a neurobiological disease, and there is impaired control over drug use, compulsive use, and it's continued despite harm and craving. This is what addiction means. And so most of our patients, if we titrate, if we give them the medications properly, and especially the oral medicines, it's very hard to find them getting addicted. Next slide, please. Physical dependence is the adaptation which is manifested by a withdrawal syndrome. Like suppose a patient is on opioids, now has received disease-modifying therapy. You want to bring down the doses. Don't just stop the opioid the next day. What we usually do is we cut back alternate doses. and then we make it BD, and then we make it OD, and then gradually bring the medication down. So don't stop everything like a switch. I think that would help. Next slide, please. So chronic non-cancer pain and opioids, it is very much used in non-cancer pain, and there is a lot of literature in the West. We still haven't reached that phase in our country, and because I deal with cancer, most of the experience that I have is with cancer pain. Next slide, please. This is the cost per day, which is also very important. So there are times when I prefer to give a patient morphine rather than tramadol, because I know the affordability of tramadol is not there. So it does happen. So I don't think we can be really accused for that in our country. And there are so many calculations. A patient has to travel so much to come for that strip of morphine. So we need to take all these into mind even when we prescribe the medications. And even when we write transdermal patches, they are phenomenally expensive. Even for someone who can afford it, the affordability becomes an issue. So most of the times when patients merit fentanyl, if they can still do with morphine and with increasing the spacing of the dosages, many of us do follow that. Next slide, please. Just one slide on methadone. It's a synthetic opioid. It's available in some parts in our country. I'm sure Kerala has it. We have it only in Hyderabad, which is in the neighboring state. And it's a synthetic opioid. And indications are when a patient has morphine toxicity or there's complex pain, when there's renal failure. But two very important things with methadone is we need to train to use it, because it's not like a simple calculation like the way we do with morphine and fentanyl. We can almost all of us can do it all the time. Whereas with methadone, it is not like that. The equianalgesic doses are not very easy to calculate. Drug interactions are plenty, especially with the ones that we use in palliative care. Electrolyte disturbances, which again worry us, because if a patient is on chemotherapy and taking these medications and the chemotherapy is going to cause electrolyte disturbances, will our methadone worsen it? So there can be some fatal side effects, but having said that, it's still a great drug, which we need to gain more experience in. Usually our patients here, I send them to Hyderabad, we get the medication and then follow it up here, follow up over here. So that's what we are doing currently. Next slide, please. A few discussion points are how one converts. What is the morphine daily dose? How would you convert this if you want to switch? What is breakthrough dosing? These are things we need to be really comfortable when we start prescribing opioids. Now I come to the end of my monologue, and it has been really a long monologue, and doing it virtually is also very, very difficult, because I hardly ever know, and many of you just switch off your videos. So I have like 5 blank screens which are staring at me, and I'm not even sure whether you're able to hear me or not. So now I'm ready for any questions or anything that you need to ask. Now, Raji, can you just give me a break now?
Thank you, Vidya. Thank you for the presentation in detail about opioids. So we would like to hear from you, the participants.
So the session is open for doubts. You can have.
Yes, please. From CRI. You are not audible.
I hope they are now. Dr. Anchika, you are not audible. Yes, you.
Am I audible now?
Yeah, sure.
Yes?
Yes.
Thank you. I'm Dr. Anshika from CRI. And thank you, ma'am, for such a wonderful presentation on the topic. I know it's a very long topic, and I think we did a great justice to it. I just wanted to know your experience with when we prescribe tramadol, and we also give amitriptyline as a tricyclic antidepressant in a low dose. Our fear is of So what is your experience with that?
I only heard you saying that you gave tramadol and you gave amitriptyline. What did you say after that?
So, what is your experience with that? Like, how much dosage can you afford?
Yeah. Usually, now when we give these two together, it must have had a strong neuropathic pain component. So that is why you must have used it. And what we say with neuropathic pain medication is, which I'm sure Sridevi and if Dr. Rajgopal is there, they can also contribute to that, is that we do not kangaroo with the medications. We go higher with the same medication. Like when we start amitriptyline, if you have started with a 10 milligram HS dose, then you can increase it to a 25 milligram HS, then go up to BD 25 milligrams. So don't add 2 or 3 medications to neuropathic medicines. But this is something we do quite commonly. And for the opioid part of it, if suppose the patient has adequate pain relief with tramadol, usually after say 150 milligram of tramadol, I switch to morphine. Because though they say you can go up to 200, as a cost factor and in the pain control, somehow I find using morphine after the patient touches 200 milligram of tramadol a better option. And so then we put them on morphine along with the amitriptyline. So that is why those are all our adjuvants. We use it very commonly, either amitriptyline or pregabalin or gabapentin. We do use a lot of these together. So, but the highest dose that I go is about 200 of tramadol. So 150 to 200 of tramadol. After that, switch the patient to morphine.
And did you ever experience serotonin with these when you combine tramadol as well as amitriptyline?
Sorry, I can't hear you. Yeah, sorry.
Is it clear now?
I think your audio is not very clear.
Yeah, Sridevi, can you hear?
It's all right. No problem.
Anshika, you are not very audible. Would you like to send the question or comment as a chat?
Yeah, sure, I'll do that, sir. I'll do
that. But Vidya, with your permission,
yes, sir, please.
I may add something. So I also agree with Vidya that the combination of morphine with tricyclic antidepressant is the better combination. If any dose of tramadol can be replaced with an appropriate dose of morphine in theory. In practice, because we do not have a tablet strength less than 10 milligrams, giving a very small dose of morphine, say 2 milligrams or 2.5 milligrams, becomes a little difficult. We do it, but that's a bit difficult. So suppose somebody has a pain here because of the cancer in the upper lobe of the lung, causing local pain, nociceptive pain, but also a neuropathic pain down the arm. Suppose with tramadol, the pain in the chest is well controlled. You can switch over to an equivalent dose of morphine, that's 2.5 or something usually, plus amitriptyline. But very often we combine tramadol with an amitriptyline. The important point to remember is that as both have similar action on the dopaminergic pathway, it can cause a crisis, dopaminergic crisis. But fortunately, this is more of a theoretical possibility than a practical possibility, simply because in neuropathic pain, we do not often use high doses of amitriptyline. If you are using it for depression, your dose may go up to 150 or 200 milligrams a day, whereas here, usually it is 25 to 50 milligrams a day, or at the most 75 milligrams for neuropathic pain. So at that dose, true, the heart rate may go up by 6 or 10 per minute, but a serious consequence like dopaminergic syndrome is not likely. So there is a risk. It's more theoretical than practical. But in somebody with already, say, existing tachycardia and arrhythmias, maybe this is a possibility to consider. Have we got the question from Anshika and the team by chat?
Thank you, sir. That was really nice. And one more place, sir, where I somehow prefer giving morphine earlier, especially because you said lung. is because they have cough and they have breathlessness. So when we start early with morphine in these patients, it kind of really helps the cough, the breathlessness, and the pain. So that is again where I don't, even if their doses of tramadol is only about say 100 a day or even 150 a day, if the symptoms of cough and breathlessness have already begun, then I prefer to kind of go to morphine earlier. So it's something which really helps.
Absolutely. In fact, there is a strong pressure on WHO to take away the step 2 completely and go straight from non-opioids to morphine. But thank you, Vidya. Anshika, have you by any chance said a chat? You have a question? You had a question or a comment?
I think, Anshika, the keyboard is a bit far for them to type. Is that the...
Okay. So after switching off the video, would you like to speak? Maybe the audio will improve when you have switched off your video.
Dr. Anshika, can you hear us?
Yeah, she switched off the video, so maybe she'll come on.
Can you hear us now?
Yes, you can speak.
Is it clear?
Very clear.
Sir, actually, you answered my question. That is exactly what I was asking. That have you ever experienced a problem combining tramadol with amitriptyline? Because in some situations, we would like to give a weak opioid only. And because so many cancer pains are mixed pains, so we have to give amitriptyline. So we always worry increasing the dose. And of course, once we have to increase the dose of amitriptyline, we switch over from tramadol to morphine. I'm just curious, what was your experience?
So, would you consider that I have already answered the question, or do you still have a question?
No, so you answered it wonderfully. Thank you.
Okay, thanks. Thanks, Anshika.
Any more questions?
Hello, ma'am.
Yes, sir.
Yes, when you said that in your experience you haven't seen drug addiction problem when you given opioids for pain management, but what we see, I'm a psychiatrist actually, ma'am. So many times we get referral from other treating doctors when opioids have been given primarily for pain management, and they ended up becoming dependent on it. We see very frequently, I would say, almost once or twice in a week at least, see such patients. So I was wondering when you said that you do not see patients becoming dependent on opioids, and it is largely a theoretical risk. I wonder whether you were implied only opioid being used for pain management in cancer, or opioid being used in pain management of other chronic pains as well.
Thank you for that question. And the thing is, I think that is what we meant by physical dependence and psychological dependence. So physical dependence is when our patients need the medication and they need it for the pain. So confusing that with addiction may not be right. And I'm sure Dr. Rajgopal will be able to answer this better. That's one thing. Second, yes, my experience is mainly in cancer pain, because I do not give, I work in a cancer institute, and most of my patients whom I see are those with cancer. And so what I think the way you described it is more like a physical dependence and not a may not be a psychological dependence. So, Dr. Rajgopal, sir, can you please take that for me?
Yeah, Doctor, thank you very much for pointing that out, because as Vidya said, our discussion today has been mostly based on cancer. Now, unfortunately, it all possibly arose from the US and Canada. From the early part of this century, there was such a hard pressure salesmanship on opioids in those countries. And there was a widespread, rather irrational use of opioids. And a lot of opioids turned out to be used in non-cancer pain. So anybody with a severe backache, anybody with a trigeminal neuralgia. Anybody with a myofascial pain would be get prescribed opioids. So there was a paper about 5 years back which frightened us by saying that the incidence of addiction. No, Vidya, whether how much of that is physical dependence is questionable, because the criteria did not exclude physical dependence. But the fact remains that up to 10% of patients with chronic pain syndromes receiving opioids, particularly most of them received Oxycontin in USA, that was what was most promoted. Up to 10% of patients got dependent. Now, out of them, a good number, remember, chronic pain is also associated with a lot of mental health issues, personality disorders, clear depression, anxiety states, etc. And they went into this dependence. And thereafter, the international community has been more cautious. Uh, American Society of Clinical Oncology has come out with, and American Pain Society have come out with the guidelines from the cancer experience. Particularly, American Pain Society came out with the guidelines for the use of opioids in non-cancer pain, in chronic pain. So the doctor unfortunately sees the bad side of it. They seldom maybe come to us, they may be straight going to him. So he has a point, and if you are using in cancer, the risk is hardly there. That's why Vidya and I would seldom see it. But we also see non-cancer pains, we see chronic pains. So we generally follow the American Pain Society guidelines. That is, never use opioids as a first-line drug in non-cancer pains. Remember, some non-cancer pains would need opioids, say peripheral vascular diseases. They would need. So it is not generalizing as a class, but nevertheless, we don't start by thinking opioids. It is not a first-line drug. As a second-line drug, before we start using, there are some precautions that we have to take. One, we make sure that the patient understands the risk. Who would opt to become an addict? When we tell them that, look, this medicine, I'll give you limited to this dose. Never exceed the dose without consultation with us. We will not give you more than the prescribed dose at any event. And many institutions actually have a signed contract between the patient just to make sure that the point is well taken, saying that they understand the risk, agreeing that they will not have unsanctioned dose escalations, having a contract, verbal or written, between us that the dose will be increased only by mutual consent. Generally, never exceeding a dose of 20 milligrams 4 hourly in non-cancer pain, except in ischemic vascular pains. So some guidelines are necessary. Irrational use in non-cancer pains, particularly in chronic pain syndromes, are certainly not warranted. Sorry for the long speech. I realize that we have very little time for the case presentation.
Thank you, sir. Rajesh, can you start the case presentation? But I'm sure that there will be more questions from the participants, which we can take up after the case presentation.
Over to you, Dr. Malini. Dr. Malini, yes. You can speak, Dr. Malini.
Okay, good afternoon, everyone. Thank you, Dr. Vidya and Dr. Gopal. Actually, the case I'm presenting today is not of a cancer patient, actually. it is somewhere related. Like I have seen this case on March 1st, and just 2 visits she has been with me, and this is more like in context of pain, because context of pain is very much important factor, uh, be it in cancer or non-cancer patient both. So I would like to go through quickly the details about it. This is a female patient, 32-year-old, and the tentative diagnosis for this patient has been somatic symptom disorder with predominant pain. Somatic tentative diagnosis right now I'm saying because I have just seen this patient and yet to refer to either psychiatry or neurology. Her initial body vitals were noted with BMI 22.89 and BP 110/70 at the for initial assessment. Next slide, please. Next slide, please. She had a presenting complaint with shooting pain that starts from right shoulders, radiated through arms and lower back, goes till the ankle joints. She is also having associated nauseating sensation with pain. She also has vomiting with severe pain, but that repeats once in 4 or 5 days. Uh, she also is complaining about headache, constipation on and off, disturbed sleep, mainly with initiation of sleep, and but sometimes in between disturbance is also present. Next slide. She is having a treated pulmonary tuberculosis history 11 years back. Since that time, she started experiencing pain in general, but there was no specification given by the patient, like what part of body, like she was having pain, headache, or anywhere. She just complained that she was having pain at that time, and she started taking medicine for that. She couldn't report about what kind of medicine. She just said, I was giving the painkiller. And then with that, initially for 2-3 years, she continued with analgesics, taking from the physicians. But after 2-3 years, she discontinued going to the physicians, and she just started taking the medication on her own from drug stores, and she was doing all well. She said, although the pain was present, it used to come occasionally whenever she was in severe strainful condition. And then for 4 days prior to when she approached to us in neurosurgery OPD primarily, she felt very harsh aggravation pain in her pain condition, and she was unable to do any work at that time. And she was also complaining with associated headache. Next slide, please. Next slide, please. Can you change the slide, please? Yeah. She on exploration, she said no weakness, no numbness or difficulty in controlling any muscles. She had no history of palpitation or any anxiety symptom at that moment. I mean, she did not report it, and then she was also having no history of injuries or any spondylitis. On examination, mental status examination, she was quite cooperative, but her appearance was very anxious and tense, and her PMA was within normal age. She was depressed in mood, affect was anxious. Her thoughts were coordinated but yet preoccupied with pain symptoms. Like her perception was intact, and other cognitive functions were also intact, like orientation, memory judgment was intact, and grade 3 insight was present. On MMSC examination, she had to score 29. That is quite within normal limit. Next slide, please. Can you change the slide, please? Then on Bake anxiety inventory, she scored 42. That is interpreted as severe level of anxiety. Then on Bake depression inventory, she scored 25. That again interpreted as moderate depression. For pain catastrophized scale, she scored 42, which is above cutoff and indicate a catastrophic anxiety out of current pain symptoms. Her highest score on helplessness was, and then on rumination also was higher side. Although the magnification scores are were comparatively low on this at this time. Next slide, please. While assessing chronic pain assessment questionnaire, she expressed the pain. She feels like aching, pulling, and cold. It's the nature of pain she expressed, and then she rated the severity of pain 9 at pain level, with 3 to 4 severe episodes during the morning hours every day. And then pain lasts for 2-3 hours, and after taking medicine, which she goes and take from the medical store, she feels better. The answer for the cause of a breakthrough pain she gave is like while she waters the plant, cooks, or do any household work, she just aggravate the pains. Then this breakthrough pain affect her daily ability, like handle daily responsibility at home, and that is her main concern actually. But still, she is not on a regular medicine. Whenever she is having very severe pain and she's not able to get up, she just takes some analgesic or again from the on her own. Next slide, please. This MRI brain was she just reported like in 2018 somewhere from outside she did this, and that showed a normal study. Here at Pi Clinic, I did the personality assessment, seeing the features, and in that she showed high score description indicating emotionally stable, dominance, moralistic, socially bold, and high strength of self-sentiment. Although her pre-morbid personality traits are social and introvert. Next slide, please. And psychophysiological responses, it is done through computerized stress profile as a software over here. And on that, in 15 minutes assessment session, her heart rate raised at 90 to 95, and her usual range was between 80 to 84. Then her respiration rate and GSR peaks were again higher on unpleasant situations. Her temperature was within lower range throughout the test, and then her blood pressure was higher throughout the test within this 135, 145 systolic range and 100 and 114 systolic range. Then in psychosocial aspect, she is a graduate and married since 13 years. She was married at the age of 19. She has two children, 7 years and 4 years, living with mother and she's living with mother and father-in-law. Husband is placed in Indian Armed Forces. She has to carry all the household responsibilities. And recently, the death of her elder sister is 7 days prior to present episode of pain. I have highlighted this because this is the current onset, although she did not report it, and that's why like in somatic symptom disorder, mostly patients they just are not consciously aware about the psychological stress of it. Next slide, please. And then, as she said, there's no medications, from any medical doctor, and she even she said even in these last 10-15 days she was not taking any medicine, and she just straight came to our hospital to neurosurgery OPD. Next slide, please. Her main concern was shooting pain and disturbed sleep, and because of that she is not able to manage the children. In summary, we can say this is a 32-year-old married female from Rani Pokhari, Dehradun, presented with chronic shooting pain, severe anxiety, moderate depression, hopelessness, rumination with concern of her inability to manage her children. Now, next slide, please. The planned therapeutic management right now I have planned for her is relaxation training for anxiety symptoms, and the CBT, cognitive behavior therapy, to manage emotional response, and behavior therapy in reference to manage household responsibility when husband is away and accepting death of her sister. The discussion point or physical examination for such symptoms are still has to be explored and done. Then organic cause linked with manifestation of radiating pain, which is constantly expressing. Medication for such a condition where she is taking like analgesics on her own without any prescription or review. And then psychosocial need of patient other than the death of sister, which she is having since marriage. Actually, at the age of 19 she was having, and then immediately she was into this pulmonary tuberculosis, and then she was carrying children. And then emotional regulation and coping strategies other than CBT. Actually, this is a case. Again, I'll repeat it. It's not a it's a non-concept patient actually, and these somatic symptom cases are coming in our OPD and hospital in a quite good number. And most of the time, why I choosing this case to present it here, because the context is important. Because in this case, this patient has taken pain in the context of her household responsibilities, and which she is wearing alone, and she is also feels pressure actually. So the context of a patient, or what I would like to say is very important, whether patient is of cancer patient or non-cancer. Even in cancer also, sometimes pain aggravate because they take it in a context of horrified disease. And of course, I'm not denying that they don't feel pain, they do feel pain, but it aggravates because of that. So the context of the patient, of the pain and psychological management of that context is very important, and that's why I just tried to brought this case in this session actually. Thank you very much.
Thank you, Dr. Malini. Like last week, I mentioned that I'm so glad that people are coming up with non-cancer pain issues from Cancer Research Institute, and understanding the importance of chronic pain and how it affects the life, and thinking beyond the cancer pain. So I'm glad to hear about that. And before moving on to discussion, we have silently joined person, that is Dr. Rajashree, who is the course coordinator of Pallium India. So she's also there for more discussion, madam. Uh, so should we start on the pain assessment in such patients? So over to Dr. Rajgopal, because I guess we see a lot of non-cancer pains here, and we do get a similar experience here with us.
You say that our Rajashree is also present somewhere. She is not visible. Is she on? Sri,
Yes,
did you say that Dr. Rajashree has
yes,
joined this session?
yes. She has joined in between, so yeah,
But now she's gone.
she's still
Yes, sir,
there.
but
I think
Hey,
she's
Raji,
sir,
please.
I'm traveling, so I may miss connectivity in between, sir. That's the
Yeah.
reason why I have
But
put my
if
video off.
you heard the case history, so
Partly.
do you have anything to offer?
Sir, I have heard the case only, I mean, on
Okay, not
partially
completely.
towards the
Vidya,
second half.
okay. Vidya, you have anything to offer? Would you like to start?
Actually, I should congratulate Malini for this presentation. It was really nice, and very honestly, I would say it's easier to treat cancer pain than non-cancer pain. Very honestly, and being in the armed forces, having tuberculosis, a marriage like this, and all the things that you said, and losing a sister in 1 week, I think 1 week ago, is all of these are huge stressors.
Right.
So I don't want to take time off Dr. Rajgopal because I want to hear what he says. So
Thank you, Vidya. I echo what Vidya said, Malini. I'm very glad that you brought this story up. I'm also glad that you are there. I mean, somebody who understands people in chronic pain is hard to find. I was for a moment trying to place myself in her place. Practically a single parent, having to deal with that itself is unimaginable for a lot of people. With a certain personality that is more predisposed to issues like this. Malini will know much more about those personalities than I. So, single parent with all the problems to face, possibly physical cause for pain, which is very likely to be lost among all the vague symptoms. Here, the story of the description of the pain, radiating pain from the shoulder to the ankle, that does not easily fit in with what we can associate with a certain group of nerves or a nerve or a single nerve. And therefore, the immediate response from me could possibly be, look, this is not physical. And the moment I say that to myself, I am practically mentally abandoning the patient. Because, well, there's nothing for me to do. I mean, there is no problem. You really are imagining it all. Is what my face may convey to the patient. Remember what Malini said. She has seen doctors, but she's not following any of their prescriptions. She's going to the pharmacist and taking medicines. The pharmacist, obviously, not knowing the story, is not judgmental like the doctor. I am likely to be judgmental. You have no problem. You are imagining it all. And a casual reference to the psychiatrist without explanations. Refer to psychiatry OP. This is the usual story. So that's one thing. On the other hand, we are likely to miss a physical factor which may be at the root of it all. So that also needs to be explored. But just concentrating on one physical finding somewhere and starting to interventions on that may only reinforcing several aspects of the pain. So here we need Malini cloned and sent to every hospital in the country. There is somebody who will sit down and listen, understand the person, convey empathy, at the same time, not getting manipulated. If I were in that woman's shoes, with all the pain, if I find a kind doctor or psychologist, I would want more and more of her empathy. And for that, I may catastrophize my symptoms more, not consciously. It's a protective response of any human being. To attract Malini's sympathy, I catastrophize more. And that's a vicious circle. So, what would I do? I would leave a lot to Malini, but first I'll do a proper physical symptom. I should not be judgmental. I should make sure that all physical problems are identified, which may not only be the cause of the pain, which may also be the consequence of pain. I wouldn't be surprised if she has 5 myofascial trigger points which are perpetuating the pain. It should have started the day after the sister's death, a whole night without sleep, or 2 or 3 nights without proper sleep, the whole body tensed, or vertebra getting losing the curvatures, more pressure on the nerve endings, worsening of all pain. She could well have myofascial trigger points which may need to be desensitized. Or she could have a cervical disc prolapse with mild, maybe only mild impingement of the nerve roots. So she needs medicine, appropriate physical examination, and as necessary, analgesics. But remembering what, I'm sorry, doctor, I don't remember his name, the psychiatrist who spoke earlier, remembering what he said, opioids should not be a first line. If we start it, it should be on a contract of dose and length of administration, because we could easily add on to her burden of suffering. Passion Khadam. I shall wait for comments.
Thank you, sir.
Yeah, Dr. Malini, would you like to?
So actually, yeah, I myself was thinking, because she has just come for initial visit and the second visit for assessment, and I myself was thinking, because the first 2 points in discussion, because of course, without exploring more about the physical, symptom, just working on context basis probably will not be much helpful. So, but still, I just wanted to be sure about it. And my next thing is like, other than for emotional regulation, other than CBT, if anybody can, because it's a point quite of two-way learning, because you could like, everyone is dealing with patients on day-to-day basis. So if it is there, it's fine.
So Malini, if I may suggest something, I think with the patient's permission, a conversation with the parents, her parents, would be a good idea. She's living with the dad and mom, right? They themselves could now be getting irritated at her.
Mm-hmm.
Their understanding of the girl's problem is vitally important. And I think the children are at great risk of growing up with a personality disorder, because they will take the brunt of the woman's anxiety and irritability. And that also needs attention. And I also suspect that the patient is at grave risk of renal failure. You know why? She's taking painkillers from the pharmacy.
Yes, sir.
She'll be given a strip of diclofenac today, a strip of ibuprofen today. She wouldn't know that both are of the same class. Yes, Malini.
No, actually, because you have mentioned this, I would like to, which this point I did not put it actually, but it was a very, one of the, also because I was a female and she could complain to me, she was having like white discharge and severe white discharge since last 15 days, since this onset of pain symptom. So I don't know how it is linked, but when you said that, I just thought to mention just to like, if it is there is some correlate relation with that. Although I have asked her to see the gynecologist also, so probably next time, next visit when she's coming, she'll be going to her also.
Maybe it is not related, I'm not sure. But I mentioned the renal failure because she needs to be educated about non-steroidal and anti-inflammatory medicines uh, and to be cautious about their use and to be hydrated when she takes it. The gynecology consultation is essential after briefing the obstetric gynecologist because, a whitish discharge is most likely harmless, but it could add on significantly to her anxiety. Here is somebody already at the pinnacle of anxiety, and she would now be fearing cancer of the uterus. So maybe a friendly gynecologist giving attention to that would be important. But thank you for bringing that point up.
Okay, sir.
Dr. Malini, I would like to ask something about have you ever had a chance to talk to her children? Like, what do they understand and what are they going through?
No, actually, because she just came on March 1st, and then afterwards, after 3-4 days, she came for the assessment. So she is yet to come, and probably next week after Holi, she'll come. So at that time, I may ask, like, because she's nearby, it's just 5 kilometers away from the hospital. So, and that time vacation will be there from the school, so probably she can bring at least the older child, the daughter, the 7-year-old daughter. So I'll ask her. Right now, I did not talk to her.
I think it's important
Of
to
course,
talk to
that can
them.
happen only after Malini has established a good enough relationship with the person, because she would immediately, she might be defensive and say, "Why do you want to talk to the kids?" That might be her reaction. So that's at the appropriate time, of course. I would
Yeah,
suggest this, but this may not be the right time. And more than me, Malini, you would know what is the best time to do that. But I mentioned that because often children are forgotten.
I know, sir. I understand, sir. Yeah, actually, there is a high chance to develop this defensive, trait in them. Like for anything, they'll just start, having this defense of being sick. So this is one of the things which is a very like quite reflective, other than other traits. So you are right, sir, and I would definitely take care of this point. Thank you, sir, for this, especially mentioning this issue.
sir, I would like to ask you another question in this context about the use of analgesics. So, would you like to elaborate a bit more on that? Like, if at all we are like her pain score she's mentioning, it is a total pain score, but still, would you like to recommend something around the clock so that she's not going somewhere and taking something which we don't know actually?
Yeah, she and all patients in chronic pain need understanding about painkillers. It is not that hard to learn, but they need to understand the role of paracetamol, how safe that is within the stipulated dose, the risks of non-steroidal anti-inflammatory medicines, and the risks of opioids, and the benefits. So once they understand it, most of them will use it safely, unless they have a suicidal tendency. So that education is necessary, and leaving them with nothing. No, you don't have. Your pain is emotional. You don't need painkillers. Also, may leave them uh, desperate. So maybe once they have understood analgesics, para, offering them paracetamol as necessary, and certainly taking their history. They will give you all the history. They'll give you a list of painkillers, but of course, most of them would be trade names. By sitting down with her and helping her to understand the various types and finding out what does help her, and offering that as judiciously only for not more than so many doses, not more than so much, not more than such stipulated dose, etc. That would be a good thing. I'm glad you pointed that out, Sri. There should be a clear understanding of what she can have for any pain aggravation. Remember, all the history points out that she has a strong psychological background to the pain. That doesn't mean that there's no physical pain. We know very well that psychogenic pains do cause constant uh, muscular reaction and the contraction of muscles and myofascial pains. So she would need analgesics, but judiciously.
Thank you,
would
sir.
like
Because, yeah, thank you.
I would like to add one thing, sir. Like other than opioid, for relaxation training is again have proven, at least my patient where if I work here, they actually respond very fast to the to reduction of symptom actually. So this is something which also we need to incorporate in our medical practice. We can train the patient for simple breathing relaxation training techniques. So this helps two ways. One, it immediately works to relax the muscles. Plus, it deviates the thought process and actually, because just concentrated thought on pain itself aggravate the pain. So such practices also to be incorporated. I do work here with patients and they respond in very well manner actually. So this is one thing I wanted to add actually.
Malini, my response to that, total agreement. They can be very valuable. Nevertheless, a word of caution. Remember that if they find a good doctor or a good therapist, almost every patient with chronic pain responds well initially. The initial, and they themselves will tell us often, when I see a good doctor, when I see a new doctor, I feel initially better with any treatment. But no, say for example, no journal of pain will accept a paper unless the follow-up is more than 3 months.
True, sir.
Because the initial response is usually good. And after about 3 weeks, after the peak, it tends to drop. So just a bit of caution before we assess the success of a treatment regime in a chronic pain. We have to give it enough time and enough follow-up. Otherwise, we'll think everything is fine and they'll disappear after 2 weeks. They don't come back to you. Before treatment has failed, they don't come back to us. If they perceive this treatment is failing me, they go to a new doctor. So every doctor thinks I have done the person good. So that's just a word of caution. And one more point to the oncologist, a good number of cancer survivors end up with chronic pains. They are the unseen martyrs. And they are usually not welcome to cancer OPs anymore. You are cured. You don't have to come back like this. Come back once in 6 months for your review, maybe what they hear. So significant incidence of chronic pain occurs among cancer survivors for a variety of reasons. And that is something that really needs to be addressed too. That's another group for Malini to see.
Thank you. Yeah, you're right.
So, any queries from the CRI group there? We didn't hear from any other participants. Dr. Priya, Dr. Saurabh. So, is there anything that you would like to discuss?
Sri Rajeshri has sent a message, a chat, saying please mention the guidelines on the chat. American Pain Society guidelines. What I'll do is, Raju, I'll email you the American Pain Society guidelines for treatment of non-cancer pain, so that you can share it with everybody.
Sir, I will share it with you.
Okay.
So, along with the learning points, you can send the guidelines also, right?
Okay, ma'am, I will do it. So, any more queries? I think we can have one more.
I wanted to thank Dr. Rajgopal sir to be there for the whole session today. That was really wonderful, very helpful.
Yeah, Anshika.
Thank you, sir.
If there is nothing else to be discussed at this point, should we wind up the session today? I'll be sending the summary of Vidya's presentation also along with that, because we have already crossed the time, so I didn't want to summarize it again. So I'll be sending it through email.
For the last 2 sessions, I have sent every materials. I hope everyone have received it. And I really would like to thank Dr. Vidya for taking this class for us, finding time in the midst of her busy schedule. Every time I call her. Thank you, ma'am, so much.
Thank
Vidya
you.
is the busiest doctor in the whole of India. Oh my
please,
God!
sir,
No, really. I have seen how you work, Vidya. I mean, it's amazing the amount of work that you take on.
So please, you don't say that. It makes me feel very embarrassed. I'm sitting in front of a global authority. So thank you. It was so nice to have you. I enjoyed that the most. It's always a treat to learn.
Okay.
Thank you, everyone. Sri, bye.
Yeah, bye-bye. See you all next week on Saturday.
Yes.
So see you all next Saturday with the continuation of this management of pain with adjuvants taken by Dr. Rajasri. Thank you all. See you on next Saturday. Bye.